Okay, so we were doing the pain history. Okay, so in the pain history, we did that we will ask the patient the onset, the mechanism of action, the 24-hour pattern of the pain, the aggravating and the relieving factor, and the irritability and the sensitivity. So I was telling you that if the pain comes on very quickly after the aggravating factor and it stays for a long time, that is a characteristic of a chronic pain. That means the patient is having that pain from a very long time. Okay, but what is a characteristic of the acute pain? That acute pain will come after some time the patient has undergone or the patient is doing the aggravating activity or the aggravating factor. Okay, and it will also get relieved very quickly. That means it will go away very quickly. So these are the characteristics of the chronic and the acute pain. Now, I was telling you that what kind of characteristic, one more characteristic that chronic pain has, that because the person is having the chronic pain from since a very long time. Okay, they may be having this pain from 3 years, 4 years. Some people tell that I am having this pain from 10 to 15 years. Okay, so just imagine that how chronic that pain would have become, and they have, they have learned to live with that pain in the on a regular basis. Okay, so usually chronic pain. Okay, if I was telling you that if there is an acute pain, if there is an acute injury, the injury or the effect of the pain or the inflammatory process, it remains localized. Okay, the patient will be telling me that I am having pain only in this local area. It will not be radiating. Okay, but chronic pain, it will go from the point of origin to some other place. Okay, it might be referred pain, it might get radiated. Okay, and what happens that in such a long time, the chronic pain will enter the central nervous system. Okay, so any of the factors, if they are having any stress, if they are, if the life is not going, in a too much good manner. Okay, or if they are stressed about something, they are having some problems. Okay, so each and every little bit of thing can also aggravate their pain. Okay, because now that chronic pain, the sensitivity, it has entered their brain, it has entered their central nervous system. Okay, so we call it as a muscle memory, right? That if a person was having a pain, for example, due to some injury, and they had suffered a lot due to that pain for a very long time. Okay, now after even they get recovered and they they had a proper rehabilitation, after a long time also, if same kind of mechanism of injury occurs again. Okay, or for example, there was an athlete and he goes to the same kind of field progress, he goes to the same kind of mechanism of action in the field, so it might trigger his pain again. Okay, so these are some of the characteristics of the pain mechanism. These are some characteristics of the acute and the chronic. Okay. After that, we will be seeing the pain scales, that what are some of the pain scales that we use for assessing the patient. Okay. So some of the pain scales that we are very regularly aware about are the NPRS, numerous pain rating scale, or the VAS scale. Okay. Visual analog scale. Okay. So there are some ratings from the scale of 0 to 10 where we will be telling the patient that 0 is no pain at all. Okay. That you are absolutely fine. You feel no pain, no pain, nothing, and nowhere in your body. But 10 is the most excruciating type of pain that you have ever experienced in your life. Okay, usually we give the examples that the women suffer from labor pain. Okay, so for them that labor pain is on a scale of 10. Okay, so according to that level, or according to comparison to that level, where does your pain lie at this point of time? Okay, so according to that, we ask the patient that on a pain scale of NPRS or on a pain scale of 0 to 10, okay, how much would you rate your pain? Okay, now if someone cannot understand, okay, that on a scale of 0 to 10, how much would they rate their pain, we can show them these kind of emoticons. Okay, that out of this is the no pain at all, this is worst possible pain, this is moderate pain. Okay, so according to these emoticons, according to these emojis, at what level is your pain at this point of time? Okay, then after asking them the pain, we will just quickly see that how do we start with the shoulder assessment. Okay, so whenever I'm doing any assessment for the shoulder, our shoulder injuries or shoulder conditions, we will be dividing them in three different categories. Okay, either the shoulder may be stiff, okay, in which when I will be checking the active range of motion and passive range of motion of the person, it will come out to be restricted. Okay, not totally restricted, but to the maximum extent it will be restricted. Okay, what I told you earlier, that first of all we will be checking the active range of motion, okay, and then we will come to the passive range of motion. So if the active range of motion is good, but passive range of motion is not coming, that will usually not happen. Okay, but what if the active range of motion is restricted, but passive range of motion is good? That means there is some injury or there is some dysfunction, abnormality lying in the muscle tissue, muscular tissue. Okay, because actively who is doing my movement? My muscles, my tendons, my ligaments are performing the movement. Okay, but whenever I am taking the movement passively, okay, when as a therapist I am implying the movement, I am performing the movement, and the patient doesn't have to put any effort at all. That means the whole performance lies on me and the muscle doesn't have to work at any point of time. That means there is if passive range of motion comes to be full at that time, that means surely there was an issue in the muscle, okay, or there was some issue in the strength or power of the joint. Okay, but there was nothing inside the joint that was restricting the movement. Okay, which would happen if active range of motion and passive range of motion both come out to be restricted. Okay, that means there is some structure lying inside the joint between the articulations. It may be, tightened capsule, it may be stiff capsule, it may be inflammation of the cartilages, it may be inflammation of the capsule over here, for example, osteoarthritis, rheumatoid arthritis, gouty arthritis, inflammation of the joint, frozen shoulder, adhesive capsulitis. What is happening over here, that when I'm checking the active range of motion of the person as well as when I'm performing the movement on my own passively, both of the times the movement is coming to be restricted. Okay, that means there is something lying inside the joint which is not allowing the joint to move properly till the end range of motion. Okay, so we divide the shoulder into stiff shoulder if the passive and active both the ranges of movement come out to be restricted. Okay, then we will be next category, the second category is the unstable shoulder, right? So unstable shoulder means there is any history of trauma. Okay, it may be history of trauma, the person might be having a push injury, they might be god forbidly involved in a road traffic accident, like that. Okay, so unstable shoulder, the patient will always be coming with their shoulder like this to me, okay, internally rotated, adducted, and giving support with their opposite arm. Okay, and they will be saying that I'm feeling like my shoulder will go away, okay, or I have dislocated my shoulder, anything may be possible. Okay, and if the shoulder, when we are doing the assessment, if the shoulder doesn't fall in the category of stiff shoulder and it also doesn't fall in the category of the unstable shoulder, that means definitely it is either a weak or a strong shoulder. Okay, we can say weak or strong painful shoulder. Okay, that means whenever we will be checking the restricted range of motion, okay, active range of motion will be restricted definitely over here. Okay, but passive range of motion will not be restricted. That means there is some dysfunction, there is some injury that is lying in the muscular area. Okay, the things or the muscular, the soft tissue structures or the skeletal structures that are producing the movement, that are helping produce the power and strength to move any joint. Okay, so we will be dividing our shoulder assessment into these three categories. Okay, now after that, in every patient, obviously we will be doing our postural analysis, right? We did the postural analysis in the front plane, the lateral sagittal plane, and the posterior part. Okay, okay. After that, we will be doing the strength testing. Okay, so first we will make the patient do active range of motion. We will check the passive range of motion, and then we will go for MMT, right? Manual muscle grading or manual, strength testing of the muscle, that against resistance, how much, good power the muscle has. Okay, against resistance, how much good power or strength it can produce. That is the strength testing. Okay, so usually either we use the MMT grading chart, manual muscle testing, okay, or we can go for isometric resisted testing. Okay, that means if I have to check the shoulder of the patient, that how good their deltoid strength is, how good their rotator cuff strength is. Okay, what I will do, I will just tell the patient to perform isometric movement of the shoulder. Okay, I will tell them to perform shoulder abduction and I will restrict the movement. Okay, so that only isometric movement is occurring. Okay, so they might say that they are having pain while doing isometric movement, or they might not be having pain while doing the isometric. Okay, their strength may be good while doing isometric movement, or the strength may not be good, they may be feeling weak. Okay, okay. Then after doing all the assessment, if we are still not feeling sure about a certain diagnosis, then we go for some special tests. Okay, so special tests are only there, and we can rely on some of the special tests only if they are having a good research value. That means they are more valuable, they are more reliable. I can rely on them more to either rule in a diagnosis or rule out a diagnosis for my differential diagnosis. Okay. So special tests are only used to confirm our findings. Whatever we did in the musculoskeletal assessment, whatever we did through the neurological assessment, when we are coming to our provisional diagnosis, special test only adds a cherry on cake. Okay, if we are whatever kind of special test we are doing and we are applying in the patient, that either comes out to be positive or negative and gives a direction to a differential diagnosis. Okay, otherwise mainly and majorly 90% of the assessment depends upon our assessment skills, our proper history taking, okay, subjective, objective, postural analysis, all these examinations of the patient. Okay, now, there are some special tests, okay? There are many special tests like that, okay? But there are usually very specific, or, only a few number of special tests that have a good amount of research value, okay? That means they are more valuable, they are more reliable. That means I can rely on them more to either rule in a diagnosis or rule out a diagnosis. Okay, so if you see, whenever you are doing any test, okay, for example, you are trying to do Hawkins Kennedy test for shoulder impingement. Okay, just try to find out their specificity value and sensitivity value whenever you are trying to rely on that test. Okay, to either if you want to rule out a diagnosis or you want to rule in a diagnosis. Okay, so any test having more than 70% or 80% amount of specificity and sensitivity would be a good test to use. Okay, for example, over here, Yergason's test we are using for checking the biceps tendinopathy. Okay, but instead of Yergason's test, Pete's test is more reliable according to the researchers. Okay, then sulcus sign is very much visible. We can see it in the dislocation of the shoulder. Okay, then we can use Job's test for supraspinatus tear for testing the rotator cuff tendinopathy or supraspinatus tear. Okay, because it has a sensitivity value of 88%. Okay, that means if my test comes out to be positive, the Job's test comes out to be positive, then along with all the symptoms and along with all the provisional diagnosis and observation of my assessment skills, whatever I'm going towards a provisional diagnosis, I can rule in the supraspinatus tear of the patient. Okay. In the same manner, we can do drop arm test for supraspinatus tear. Okay. So supraspinatus tear has a sensitivity, drop arm test has a sensitivity of 96%. That means I can also rely on drop arm test for ruling in the diagnosis. Okay. Now, full can test also has a good amount of specificity. Lift off test is usually for subscapularis tear. Okay. And belly press test also has a good amount of specificity. Okay. So usually specificity or sensitivity more than 70%, or we can rely more on more amount of or more percentage of specificity or sensitivity. Okay, usually we rely more on more than 80%, more than 90%. Okay, now what does specificity and sensitivity mean? That whenever a special test comes out to be positive, okay, and if it is having a good amount of specificity, and that manner or at that time I can rule in the disease or I can rule in the condition. Okay, for example, if I'm checking my patient for supraspinatus tear and drop arm test comes out to be positive, okay, then after seeing all the symptoms of the patient, after assessing all the examination, musculoskeletal, neurological, everything, I can rule in the disease that yes, I did all the musculoskeletal examination, which was sending a signal towards the supraspinatus tear. Okay, and on top of that, I did a drop arm test, and usually we don't rely on one test only. Okay, we at least perform 2 to 3 tests to rule in the diagnosis. Okay, or rule out a diagnosis also. Okay, so that is why, because drop arm test came out to be positive, Okay, and all other tests for supraspinatus tear came out to be positive. That is why I'm ruling in the diagnosis that this patient might be having a supraspinatus tear. Okay, otherwise, if either one of the tests comes out to be negative, okay, so we have to check and we have to do the assessment many times. Okay, we will start the rehabilitation with the patient, but still we will be doing the assessment again and again on a regular basis. Okay, maybe weekly, maybe after 15 days or after 10 days. Okay, and now what sensitivity means? If a test is having a good amount of sensitivity value, okay, and if I'm checking a person for any condition and that test comes out to be negative, okay, that means it is also having a good sensitivity value. That means it is more reliable to help me rule out a diagnosis. Okay, for example, Job's test is having a good amount of sensitivity for supraspinatus tear. Okay, so if I'm checking a person for any rotator cuff tendinopathy and I need to rule out that it should not be supraspinatus tear, I'm going more towards the diagnosis that it should be subscapularis tear. Okay, so first I will have to rule out the diagnosis of supraspinatus tear in my differential diagnosis. Okay, so if I'm using Job's test and it comes out to be negative, that means it is helping me go more towards the confirmatory diagnosis that it is not supraspinatus tear. Okay, so like that we use the tests which are having a good amount of sensitivity and good amount of specificity. Okay, now the last thing that we will see over here to assess the shoulder movements is whenever I'm checking, I will be making my patient perform two kinds of movements whenever I'm doing the shoulder assessment. Okay, so one is the push assessment. Okay, that means I will tell them to do any pushing activity, any kind of pushing activity. Okay, I can tell them to go for a wall push up. Okay, or I can tell them to push and slide a heavy box kept in front of them, anything. Okay, so I'll be checking their push movement and I'll be checking their pull movement. Okay, usually when we are suspecting any rotator cuff injury, okay, it may be rotator cuff tendinopathy, supraspinatus tear, subscapularis tear, impingement of the shoulder, anything. Okay, so there are two kinds of movements that I may be performing for my patient. Those are push movements and pull movements. Okay, so whenever I'm checking the push movements of the patient, I'm checking usually the posterior rotator cuff. Okay, and which are the posterior rotator cuffs? The three muscles that lie posteriorly on the scapula. Okay, so first is the supraspinatus, infraspinatus, and teres minor. Okay, so these are the stabilizers for my shoulder joint. Okay, the posterior rotator cuff, sit muscle, supraspinatus, infraspinatus, and teres minor. Okay, and they are the ones that are responsible for stabilizing my pushing movements. Okay, because just imagine that when I'm doing the pushing movement, my humerus is rolling anteriorly. Okay, and who should be the one to prevent that excessive anterior rolling of my humerus? Obviously, the muscles present behind on the posterior part. Okay, so which are the muscles present behind on the posterior side of the scapula? Sit muscles, supraspinatus, infraspinatus, teres minor. Okay, so those are the muscles that we call as posterior rotator cuff. They act as stabilizers of my glenohumeral joint. Okay, and whenever I'm checking the push movements, I will be checking their strength and their stabilizing activity. Okay, now opposite happens when I'm checking the pulling activity. Okay, because in pulling activity, where is my humerus sliding? It is gliding in extension posteriorly. Okay, so who should be the one to prevent excessive extension gliding of my humeral head? It should be the one present anteriorly. Okay, so anteriorly, which muscle is there that is totally covering the scapular area? Whole anterior area of the scapula is being covered by the subscapularis, right? We studied that subscapularis cover all the area of the scapula like this. Okay, so anterior rotator cuff is the subscapularis. Okay, and anterior rotator cuff, the subscapularis, little bit of pectoralis major and minor. What they do? They are the stabilizers as well as the active movers of my glenohumeral joint. Okay, so whenever I will be checking the pulling movements of the shoulder of my patient, I am checking the stabilizing activity, and active movers activity. That is, I'm checking the strength and stabilizing and normal activity of the subscapularis, little bit of pectoralis major and minor. Okay, and then how can I check the pulling movements of the shoulder of my patient? I can do in rows. I can tell them to do rows. I can tell them to do pull-ups or face pull-ups, anything. Okay, so anything requiring this pulling activity. Okay, so with this, we finish with the assessment part.